Cardiovascular Pharmacology questions and answers for Nursing RN students. Question 1. Reginald is 73 years old. He has atrial fibrillation and takes warfarin. His INR has been stable at 2.5 for 6 months. He starts taking ciprofloxacin for a urinary tract infection. 3 days later, his INR is 5.8. He has no bleeding. What caused Reginald's INR to rise? Option A. Ciprofloxacin increased warfarin absorption. Option B. Ciprofloxacin killed gut bacteria that produce vitamin K. Option C. Ciprofloxacin inhibited warfarin metabolism. Option D. Ciprofloxacin caused liver damage. The correct answer is option B. Ciprofloxacin killed gut bacteria that produce vitamin K. Ciprofloxacin and other antibiotics kill gut bacteria that synthesize vitamin K. Less vitamin K means warfarin becomes more potent. The INR rises. This interaction is common with broad-spectrum antibiotics. Reginald does not need to stop warfarin. His dose should be reduced temporarily or he can be monitored closely. The nurse who knows this interaction prevents a bleeding complication. Reginald's INR will return to baseline when he finishes the antibiotic. Question 2. Tammy is 42 years old. She has no medical problems. She presents to the emergency room with crushing chest pain. Her EKG shows ST elevations. She is diagnosed with a myocardial infarction and given aspirin and ticagrelor. She also has a history of gout. The next day she develops severe pain, swelling and redness in her left big toe. Her uric acid level is 9.5. What caused Tammy's gout flare? Option A. Tammy had a gout flare unrelated to her medications. Option B. Aspirin caused Tammy's gout flare. Option C. Ticagrelor caused Tammy's gout flare. Option D. Tammy's heart attack caused her gout flare. The correct answer is option B. Aspirin caused Tammy's gout flare. Aspirin at low doses such as 81 mg increases uric acid levels by reducing kidney excretion. A gout flare can occur within days of starting aspirin. Ticagrelor also increases uric acid but less potently. Tammy needs treatment for her gout flare with colchicine or NSAIDs, but NSAIDs are contraindicated after a heart attack. Colchicine is safe. The nurse who blames ticagrelor alone misses the primary culprit. Aspirin triggered Tammy's toe. Question 3. Wilson is 77 years old. He has hypertension and takes doxazosine for benign prostatic hyperplasia. He is started on tamsulosin for his prostate symptoms. His primary care provider tells him to stop doxazosine and continue tamsulosin. Wilson asks his nurse why he cannot take both. What is the best response? Option A. Taking both alpha blockers can cause severe hypotension and falls. Option B. Taking both alpha blockers is safe but expensive. Option C. Doxazosine stops working after 1 year. Option D. Tamsulosin works better than doxazosine. The correct answer is option A. Taking both alpha blockers can cause severe hypotension and falls. Doxazosine and tamsulosin are both alpha blockers. Doxazosine is non-selective alpha-1 blocker. Tamsulosin is alpha-1A selective. Taking both causes additive vasodilation, orthostatic hypotension, and falls, especially in older adults. Wilson should take one or the other, not both. The nurse who lets Wilson take both puts him at risk for a hip fracture. Wilson's prostate will improve on tamsulosin alone. His blood pressure will need a different drug class if still elevated. Question 4. Bernice is 58 years old. She has hypertension and takes losartan 50 mg daily. She becomes pregnant. She tells her nurse she stopped taking losartan when she found out she was pregnant at 6 weeks gestation. She is now 20 weeks pregnant and her blood pressure is elevated. What is the best action? Option A. Restart losartan at a lower dose. Option B. Start labetalol or methyldopa instead of losartan. Option C. Continue losartan but add aspirin. Option D. Start nifedipine but continue losartan. The correct answer is option B. Start labetalol or methyldopa instead of losartan. ACE inhibitors and ARBs like losartan are contraindicated in the 2nd and 3rd trimesters due to fetal kidney damage, oligohydramnios, and fetal death. Bernice should never restart losartan during pregnancy. She needs labetalol, methyldopa, or nifedipine, which are safer. The nurse who restarts losartan causes fetal harm. Bernice's baby is at risk. The correct drugs protect both mother and child. Question 5. Chester is 64 years old. He has stable angina and takes nitroglycerin sublingual as needed for chest pain. He has a prescription for sildenafil or Viagra for erectile dysfunction. He tells his nurse that he took a nitroglycerin tablet for chest pain 1 hour after taking sildenafil. He felt fine. He asks if the interaction is real or just a myth. What is the best response? Option A. The interaction is a myth. You can take both safely. Option B. The interaction is real but only with nitroglycerin patches, not sublingual. Option C. The interaction is real and potentially fatal. You were lucky. Never take them within 24 hours of each other. Option D. The interaction only occurs with sildenafil, not with tadalafil or chalis. The correct answer is option C. The interaction is real and potentially fatal. You were lucky. Never take them within 24 hours of each other. The combination of nitrates and PDE5 inhibitors like sildenafil causes profound vasodilation and severe hypotension that can be fatal. The interaction occurs with all nitrates including sublingual, spray, patch, and paste. Chester was lucky. He may not survive a second exposure. The safe window is 24 hours for sildenafil and 48 hours for tadalafil. The nurse who dismisses this as a myth causes a patient death. Chester must choose between angina treatment and erectile dysfunction treatment. He cannot have both. Question 6. Annette is 69 years old. She has heart failure with reduced ejection fraction and takes metoprolol succinate 200 mg daily. She is admitted for pneumonia and her heart rate is 52. The night nurse holds her metoprolol because the heart rate is below 60. The morning nurse notices Annette's heart rate is now 88 and her blood pressure is 150/90. What happened? Option A. Annette's pneumonia worsened overnight. Option B. Metoprolol withdrawal caused rebound tachycardia and hypertension. Option C. Annette received albuterol nebulizers which increased her heart rate. Option D. Annette had a pulmonary embolism. The correct answer is option B. Metoprolol withdrawal caused rebound tachycardia and hypertension. Abrupt withdrawal of beta blockers like metoprolol causes rebound sympathetic activation. Heart rate increases. Blood pressure increases. Myocardial oxygen demand increases. This can trigger heart attack or heart failure decompensation. The night nurse made a common error. Beta blockers should be continued unless the patient is in cardiogenic shock. A heart rate of 52 in a patient with heart failure is therapeutic, not dangerous. The morning nurse restarts metoprolol and Annette stabilizes. Question 7. Samuel is 55 years old. He has chronic kidney disease stage 4 with an eGFR of 25. He has atrial fibrillation and needs anticoagulation. His provider wants to prescribe rivaroxaban or Xarelto. Samuel asks his nurse if this is safe with his kidney disease. What is the best response? Option A. Rivaroxaban is safe in all stages of kidney disease. Option B. Rivaroxaban is contraindicated in patients with creatinine clearance below 15. Option C. Rivaroxaban requires dose adjustment for kidney disease but can be used. Option D. Rivaroxaban should never be used in any kidney disease. The correct answer is option B. Rivaroxaban is contraindicated in patients with creatinine clearance below 15. Rivaroxaban is eliminated by the kidneys. In patients with creatinine clearance below 15, it is contraindicated. For patients with moderate kidney disease, the dose is reduced from 20 mg to 15 mg daily. Samuel's eGFR of 25 is moderate impairment. He can take rivaroxaban 15 mg daily. The nurse who says it is completely safe or completely unsafe is wrong. The correct answer is dose adjustment. Ipazaban is often preferred in kidney disease because it is less reliant on renal excretion. Question 8. Henrietta is 72 years old. She has hypertension and takes hydrochlorothiazide 25 mg daily. She presents to the clinic with fatigue, muscle weakness, and constipation. Her EKG shows a prolonged QT interval and flat T waves with prominent U waves. Her potassium is 2.9. What is the most likely cause? Option A. Hydrochlorothiazide caused hypokalemia. Option B. Henrietta has hyperaldosteronism. Option C. Henrietta has renal tubular acidosis. Option D. Henrietta has Cushing syndrome. The correct answer is option A. Hydrochlorothiazide caused hypokalemia. Thiazide diuretics like hydrochlorothiazide cause potassium wasting. Henrietta's potassium of 2.9 is severe hypokalemia. The EKG changes including U waves and prolonged QT are classic. Hypokalemia increases the risk of Torsades de Pointes and cardiac arrest. Henrietta needs 4 and oral potassium replacement. She also needs to stop hydrochlorothiazide and switch to a potassium-sparing diuretic or a different drug class. The nurse who misses this EKG finds Henrietta in cardiac arrest the next day. Question 9. Marvin is 48 years old. He has no medical history. He presents to the emergency room with severe chest pain after using cocaine. His blood pressure is 190/110. His heart rate is 130. His EKG shows ST elevations. The emergency physician wants to give labetalol for his blood pressure. What should the nurse do? Option A. Give labetalol as ordered. Option B. Hold labetalol and request nitroglycerin or phentolamine. Option C. Give half the ordered dose of labetalol. Option D. Give labetalol with a calcium channel blocker. The correct answer is option B. Hold labetalol and request nitroglycerin or phentolamine. Cocaine-induced chest pain and hypertension are caused by alpha-adrenergic stimulation. Beta blockers like labetalol block beta receptors but leave alpha receptors unopposed. This worsens coronary vasoconstriction and can cause death. The correct treatment is a vasodilator like nitroglycerin or an alpha blocker like phentolamine. The nurse who gives labetalol as ordered may kill Marvin. This is a classic board question and a real patient safety issue. Hold the labetalol and call the physician back. Question 10. Dorothy is 79 years old. She has heart failure with preserved ejection fraction and takes furosemide 80 mg daily. She presents with profound weakness and dizziness. Her sodium is 125. Her potassium is 4.0. Her glucose is normal. She has no other medical problems. What caused Dorothy's hyponatremia? Option A. Furosemide caused hyponatremia. Option B. Dorothy has SIAD from lung cancer. Option C. Dorothy has adrenal insufficiency. Option D. Dorothy is drinking excessive water because she is always thirsty. The correct answer is option A. Furosemide caused hyponatremia. Loop diuretics like furosemide can cause hyponatremia but less commonly than thiazides. The mechanism is sodium loss combined with water retention. Dorothy's sodium of 125 is severe. She needs to stop furosemide temporarily and may need 4 hypertonic saline. Her diuretic should be switched to a different class or the dose reduced. The nurse who assumes furosemide is safe for hyponatremia is wrong. It happens. Dorothy almost had a seizure from low sodium. Question 11. Lawrence is 44 years old. He has hypertension and is started on clonidine 0.1 mg twice daily. He tolerates it well. His provider increases the dose to 0.2 mg twice daily. Lawrence takes the first increased dose and then falls asleep on the couch. He cannot be woken up. His wife calls 911. His blood pressure is 80/40. His heart rate is 50. What caused Lawrence's altered mental status and hypotension? Option A. Lawrence had a stroke. Option B. Clonidine overdose caused hypotension and sedation. Option C. Lawrence had a seizure. Option D. Lawrence has adrenal crisis. The correct answer is option B. Clonidine overdose caused hypotension and sedation. Clonidine overdose causes profound hypotension, bradycardia, and central nervous system depression including sedation, lethargy and coma. Lawrence's dose was doubled. He is sensitive to the medication. He needs 4 fluids, possibly atropine or dopamine, and close monitoring. Clonidine should be started at low doses and titrated slowly. The nurse who recognizes clonidine overdose saves Lawrence from unnecessary head CTS and stroke workups. Lawrence will wake up as the clonidine wears off. Question 12. Bernadette is 66 years old. She has peripheral artery disease and takes silostosol or Plital 100 mg twice daily. She asks her nurse how this medication helps her leg pain when she walks. What is the best response? Option A. Silostosol dilates your leg arteries so more blood gets to your muscles. Option B. Silostosol prevents blood clots in your leg arteries. Option C. Silostosol inhibits platelets from sticking together. Option D. Silostosol improves walking distance by vasodilation and inhibiting platelet aggregation. The correct answer is option D. Silostosol improves walking distance by vasodilation and inhibiting platelet aggregation. Silostosol is a phosphodiesterase type 3 inhibitor. It causes vasodilation of leg arteries and inhibits platelet aggregation. It also has inotropic effects on the heart. The result is improved walking distance in patients with intermittent claudication. Bernadette's leg pain is from insufficient blood flow. Silostosol helps but takes 2 to 3 months to work. The nurse who says it only dilates arteries misses half the mechanism. The nurse who says both is correct. Bernadette understands why she is taking this pill. Question 13. Randall is 61 years old. He has heart failure and takes spironolactone 25 mg daily. He also takes ibuprofen for arthritis. He presents with weakness and confusion. His potassium is 6.8. His creatinine is 2.5, up from 1.0. What caused Randall's hyperkalemia and kidney failure? Option A. Spironolactone alone caused hyperkalemia. Option B. Ibuprofen alone caused kidney failure. Option C. The combination of spironolactone and ibuprofen caused hyperkalemia and kidney failure. Option D. Randall has undiagnosed adrenal insufficiency. The correct answer is option C. The combination of spironolactone and ibuprofen caused hyperkalemia and kidney failure. Spironolactone is a potassium-sparing diuretic. Ibuprofen is an NSAID which reduces kidney blood flow by blocking prostaglandins. Together they cause hyperkalemia and acute kidney injury. Ibuprofen should be avoided in patients on spironolactone. Randall needs 4-calcium gluconate, insulin with dextrose, and K-oxalate. His spironolactone and ibuprofen must be stopped. The nurse who gives both medications together causes preventable harm. Question 14. Tanya is 34 years old. She is 32 weeks pregnant. She has chronic hypertension and takes labetalol 200 mg twice daily. She presents with a blood pressure of 170/110 and proteinuria. She is diagnosed with preeclampsia. The provider orders 4-hydralazine. Tanya asks why she cannot just take more labetalol. What is the best response? Option A. Labetalol does not work for preeclampsia. Option B. Hydralazine is the preferred 4-agent for acute severe hypertension in pregnancy. Option C. Labetalol can cause fetal bradycardia at high doses. Option D. Both B and C are correct. The correct answer is option D. Both B and C are correct. In preeclampsia with severe hypertension, 4-hydralazine and 4-labetalol are both first-line, but high-dose labetalol can cause fetal bradycardia. Hydralazine is often preferred for acute management. Tanya needs rapid blood pressure control to prevent stroke and seizure. The nurse explains both options. Tanya receives hydralazine and her blood pressure normalizes. Her baby is monitored closely. Question 15. Winston is 69 years old. He has atrial fibrillation and takes apixaban or Eliquis. He falls off a ladder and hits his head. He has a 2-centimeter scalp laceration but is awake and talking. His neurological exam is normal. The emergency physician wants to discharge him after suturing his scalp. The nurse insists on a head CT. The CT shows a small subdural hematoma. Why was the nurse correct? Option A. All patients on anticoagulation with head trauma need a head CT regardless of symptoms. Option B. Patients on DOACs can have delayed intracranial bleeding without early symptoms. Option C. Elderly patients have brain atrophy which increases bleed risk. Option D. All of the above. The correct answer is option D. All of the above. Winston has 3 risk factors. He is on anticoagulation. He is elderly with brain atrophy. He hit his head. Intracranial bleeding can occur without symptoms and expand over hours. The physician was wrong. The nurse saved Winston's life. He needs neurosurgery consultation and reversal of apixaban with Andex-SA if bleeding expands. The head CT was not optional. It was mandatory. Question 16. Morris is 57 years old. He has stable angina and takes isosorbide mononitrate 30 mg every morning. He tells his nurse that the medication works great for about 6 hours, but then his chest pain returns in the afternoon. He asks if he can take a second dose. What is the best response? Option A. Yes, take a second dose in the afternoon. Option B. No, taking a second dose will cause tolerance. Option C. Yes, but take half the dose in the afternoon. Option D. No, you need to switch to a different medication. The correct answer is option B. No, taking a second dose will cause tolerance. Isosorbide mononitrate requires a nitrate-free interval of 10 to 12 hours to prevent tolerance. Taking a second dose in the afternoon would mean continuous nitrate exposure. The medication would stop working entirely within days. Morris should take his single morning dose and use sublingual nitroglycerin for breakthrough angina. If his angina returns every afternoon, he may need a different antianginal like a beta blocker or calcium channel blocker. The nurse who tells Morris to take a second dose creates tolerance. Question 17. Elaine is 73 years old. She has hypertension and takes verapamil SR 240 mg daily. She also takes simvastatin 40 mg daily. She presents with muscle pain, weakness, and dark urine. Her CK is 8,000. Her creatinine is 2.2. What caused Elaine's rhabdomyolysis? Option A. Verapamil alone caused rhabdomyolysis. Option B. Simvastatin alone caused rhabdomyolysis. Option C. Verapamil inhibited simvastatin metabolism causing toxicity. Option D. Elaine has viral myositis. The correct answer is option C. Verapamil inhibited simvastatin metabolism causing toxicity. Verapamil is a moderate CYP3A4 inhibitor. Simvastatin is metabolized by CYP3A4. The interaction increased Elaine's simvastatin level by 3 to 5 times. She developed rhabdomyolysis. The correct combination would be verapamil with pravastatin or rosuvastatin, which are not metabolized by CYP3A4. Elaine needs 4 fluids and her medication stopped. The nurse who knows this interaction prevents kidney failure. Question 18. Suzanne is 48 years old. She has heart failure with reduced ejection fraction. She takes lisinopril, metoprolol succinate, and furosemide. She tells her nurse she wants to get pregnant. What is the most important counseling point? Option A. Lisinopril must be stopped before pregnancy. Option B. Metoprolol must be stopped before pregnancy. Option C. Furosemide must be stopped before pregnancy. Option D. All heart failure medications are safe in pregnancy. The correct answer is option A. Lisinopril must be stopped before pregnancy. ACE inhibitors like lisinopril are phytotoxic in the 2nd and 3rd trimesters, causing fetal kidney damage and death. They should be stopped before conception. Metoprolol and furosemide are not first line in pregnancy but can be used with caution. Suzanne needs to switch to hydralazine and labetalol or methyldopa before attempting pregnancy. Her heart failure needs careful management by a maternal fetal medicine specialist. The nurse who fails to warn Suzanne causes fetal harm.